Good afternoon, everyone. We're just waiting another minute to let everyone merge into the office hours session. Okay. Good afternoon, everyone, and welcome to the second session of our Office Hours series addressing quality improvement principles in your infection prevention and control program. I'm Allison Spangler, Quality Improvement Advisor with the Health Quality Innovation Network, or HQIN. I'm joined today by Mary Childs, who is President and owner of Childs Healthcare Consulting, and I'm also joined by our HQIN team of infection preventionists and quality improvement advisors. We're excited to spend the next 30 minutes with you. Today's discussion will be on infection control action plans. But first, a few housekeeping items to get us started. Everyone is currently muted and in listen-only mode. If you have any questions or would like to comment, please use the Q&A icon at the bottom of your screen. All attendees will be able to see the questions and responses. If for some reason we're unable to answer all the questions during today's session, we will follow up afterwards. If you would like to ask a question or comment live, click the raise your hand icon and we will unmute you so that you can ask your question or comment over the audio line. At the end of today's session, there will be a short evaluation link posted. We'd appreciate you taking a few minutes to complete that so we may better serve you in the future. Finally, if you encounter audio challenges, click Audio Settings in the bottom left-hand corner of your screen. Listen by telephone options are in your confirmation email. So this presentation is meant to serve as a visual resource companion to our infection control action plan templates that complement the CDC Infection Control Assessment Tool. We will walk through how to develop an action plan using CMS QAPI guidance that includes SMART goal setting, root cause analysis, intervention selection, and PDSA. There is no one correct or required way to write an action plan. It's important to have some sort of written documentation that states your goals, lists your overall strategies to achieve those goals, and then outlines the specific actions you will take to implement the interventions you have selected. The sample root cause analysis, actions, interventions, and best practices illustrated in the action plans are solely intended as example guidance. They are meant to guide and stimulate thoughts in developing an action plan specifically tailored to your organization or facility. To access this and other resources that are part of our sessions, your facility will need to be an HQIN member. If you're not a member, to join, please contact your state's Quality Improvement Advisor, and they will be listed at the end of this presentation. For everyone that is already an HQIN member, you will automatically receive the recording and resources within the next few days. So let's get started. Your first step in developing an action plan is to identify any gaps or opportunities for improvement. This step involves reviewing your relevant sources of information to determine if gaps or patterns exist in your systems of care that could result in quality problems, or are there opportunities to make improvements? It's also very important to be proactive as well as reactive when identifying areas to improve upon. While taking action to reverse negative effects, such as survey deficiencies, is necessary, having systems in place to monitor vulnerabilities on a consistent basis means problems are more likely to be detected early. This provides a perfect opportunity for an improvement project that can serve to avoid a serious situation. You can utilize a variety of sources to assist you. Many of you have completed a self-assessment of your infection control program using the CDC Infection Prevention and Control Assessment Tool for long-term care facilities, for example. Self-assessments are excellent ways to identify areas that need additional work or focus. Or maybe you've looked at the frequency, scope, and severity of your F880 citations in previous surveys and identified a pattern. Perhaps you've experienced an adverse outcome related to a breakdown in your infection control program. Quick, focused stand-up meetings with management and staff are also excellent opportunities to identify concerns, resources, and needs while discussing processes and systems that don't make sense, are ineffective, or frustrating. Once you've identified opportunities for improvement, you'll want to prioritize your areas identified. Setting priorities should focus on high risk, high volume, or problem-prone areas. So today we're going to focus on hand hygiene. This continues to be one of the hot topics in infection control, and justifiably so. Our hands are the main pathways of germ transmission, which makes it probably the most important measure to prevent healthcare-associated infections, and yet many organizations struggle with compliance. Today, we're going to share the success of a 100-bed nursing home and how they work through hand hygiene from problem identification through planning and implementation. So how did they get started? They set to work reviewing their past survey deficiencies and noted that they were cited for lapses in hand hygiene in 2 inspections. Their hand hygiene citations were observed during direct resident care and medication administration. Like many of you, facility leadership observes hand hygiene multiple times a day through both formal and observational audits. So it made sense to dive in and analyze the completed audits for frequency, consistency, and number of staff observed. Wisely, the infection prevention team then interviewed staff to learn their understanding and candid perceptions on performing hand hygiene. So when reviewing the survey results, hand hygiene audits, and team member awareness interviews, it was obvious not all staff in every department were consistently performing proper hand hygiene. The infection preventionist and director of nursing also came to realize that their current auditing process does not provide them with a clear picture of the facility's hand hygiene compliance. Due to high risk for spread of infection and the problem-prone nature of not cleaning one's hands properly when caring for vulnerable residents, the nursing home leadership had an aha moment and quickly recognized hand hygiene as an area with great opportunity for improvement. So ready to dig in? So once you've identified your problem or opportunity, you're now ready to conduct a root cause analysis, or RCA, to determine the underlying process and system issues and identify barriers. High-performing nursing homes know that this step can't be skipped just because the team thinks they know the reasons for a problem. You'll need to collect and organize the facts to understand what led to noncompliance in hand hygiene. This will allow you to identify the contributing factors or situations, circumstances, or conditions causing the issue, and sometimes it's surprising by some of the root causes identified. All valid root causes need to be addressed. It's recommended to sort identified system breakdowns into categories like the ones listed here to assist in further understanding the factors involved. With a clear understanding of what went wrong, you can begin to systematically find out why it went wrong. Using our area of opportunity as our example, several factors in this nursing home contributed to staff not consistently performing hand hygiene. Hand hygiene products are not conveniently located throughout the facility. They're only located in the resident rooms, on med carts, and in nursing stations. Staff forget to wash their hands. There are no visual reminders posted throughout the facility, Reminders are only posted in the restrooms. While nursing staff receive hand hygiene education on hire and quarterly, all other departments only receive education on hire and annually. And like so many other nursing homes across the nation, some of the staff here believed that wearing gloves is a substitute for hand hygiene. Only nursing, dietary, and housekeeping staff receive routine scheduled hand hygiene audits. The QAPI team was surprised to learn that all other departments are not audited on hand hygiene compliance. And their hand hygiene compliance data is not collected or reported in a usable format that's easily analyzed and shared. So an analysis of the contributing factors led to the identification of the underlying process and system issues or root causes listed here. Notice that there is more than one root cause, and that's okay. It's normal to have more than one root cause identified. It means that you truly are investigating and analyzing the problem. So now it's time to establish a goal. Goal setting is important for any measurement related to performance improvement, and CMS recommends using the SMART formula. The goal should be descriptive yet concise enough that it can be easily communicated and remembered. When developing your goal, be specific about what you want to accomplish. Think about this as the mission statement for your goal. This isn't a detailed list of how you're going to meet a goal, but it should include an answer to the popular W questions listed on the slide. What data are you going to use to determine if you meet the goal? This makes the goal more tangible because it provides a way to measure progress. Is your goal attainable? Goals are meant to inspire motivation, not discourage. Think about how to accomplish the goal and if you have the tools or skills needed. If you don't currently possess those tools or skills, consider what it would take to attain them. Your goal should be relevant, meaning it should address the area of it for improvement you have identified. Finally, make sure the target date is realistic. Determine what can be accomplished within that time period. One of the resources that we will share at the end of today's session is the goal setting worksheet. By following the SMART formula, your goals will be appropriate, clearly stated, and describe what your team intends to accomplish. So since our nursing home does not have complete house-wide hand hygiene data, they have no starting point, no baseline. So while they want to be perfect, they realize setting a goal of 100% compliance might not be a realistic or attainable goal. So this nursing home decided to set their goal for 95%, and once they have collected data to see what their baseline data shows, they can revisit the goal to determine if it should be updated. And here's our goal on our template. So now that the root causes have been identified, it's time to evaluate each root cause to determine how best to reduce or prevent it from happening again. The key is to choose actions that address each root cause. Make sure the team involved in intervention selection has a good understanding of the resident care system or process. Consider including frontline staff in this process. At least one corrective action should be developed to reduce or eliminate each root cause. There can be more than one corrective action for a root cause. Some action plans will have short-term solutions to fix the contributing factor. However, use caution with short-term solutions because they rarely fix root causes. So after the team identified their issues based on the root cause analysis exercise, they decided to list interventions to address each root cause. They'll put a process in place to ensure all staff receive the same frequency of education. Additional hand hygiene stations will be installed to make performing hand hygiene more convenient for staff. They'll develop a schedule to ensure all departments receive both formal and observational hand hygiene audits. And a tracking tool will be developed so that a baseline hand hygiene compliance rate can be calculated and their data can be tracked and trended over time. You see here the nursing home listed the interventions and determined the start date, projected completion date, the roles of the person or persons responsible for each intervention, and any ongoing monitoring and surveillance that's involved. By identifying the roles and persons responsible for each intervention, including start and end dates, sets definite deadlines and holds team members accountable. So now that interventions have been selected, how will the nursing home team implement and know if they are having their intended effect? CMS recommends using the Plan, Do, Study, Act, or PDSA cycle to design and document interventions and to pilot test changes selected as options for improvement. It's beneficial to plan a small test of change in order to learn from failures without a large impact. This facilitates identification of necessary adjustments in the plan before implementing facility-wide. You'll want to document observations as well as problems encountered and unexpected findings. Next, summarize what was learned. Include not only successes, but also unintended consequences, surprises, and failures. Finally, record a description of the modifications you will make to the original plan to improve it. This is where lessons learned are applied to improve the process. You'll then need to decide to either adapt the plan, adopt the plan, or abandon the plan. Don't worry if you go through several PDSA cycles before arriving at solutions that achieve the desired improvement. Identifying solutions can be a trial and error process that will require making adjustments and trying implementation again to see if it works better with new interventions added. Our PDSA worksheet shown here on this slide is another resource that's available to HQuinn members. So today I highlighted our hand hygiene action plan using the example of a nursing home team that identified a problem or area of opportunity and worked through a structured process to ensure success. There are 8 additional templates we have developed on the categories listed here. They all follow the same format and include examples of areas of opportunity, root cause analysis, specific actions or interventions, as well as links to resources. These will also be shared as resources to today's session. So for those of you that are not already HQuinn members, here are our state contacts. Please reach out and they will assist you in joining our network and make sure you receive today's resources. As you review the resources or after you've had time to digest this information, feel free to email us and we'll be happy to help or get you to the right people who can. Please remember to complete the evaluation, and we also want to invite you to join us on our next 2 office hours sessions, which are on August 11th, and that's data collection and analysis, and August 25th, QAPI. Everyone has a role and a responsibility. So now I'm going to pause and see if there's any questions in Q&A or if anyone has their hands raised.
If you have a question, if you would type it in the Q&A.
And Allison, this is Amy. We do not currently have any raised hands.
Okay. Well, while we're waiting for any questions to come in, I'm actually going to pose a question to all the attendees. Has anyone found a unique issue through root cause analysis that you'd like to share? And what intervention did you implement? And you can either raise your hand to share live, or you can type your answer in the Q&A.
Allison, it's Amy, and I see that Tara Davis has her hand raised, so I'm going to go ahead and unmute you. Okay, Tara, you should be able to unmute yourself. You might have to, if you get a message on your computer that says to unmute yourself. And if not, you might need to go ahead and type it in the Q&A. I have enabled you to unmute yourself, but if it's not working for you, you might need to type your question in the Q&A. I apologize.
Okay. Hi, so we do have a question from Tracy, and it is, are hand hygiene stations outside in corridors problematic in the long-term care world with residents eating or drinking it?
And this is Allison. I have not heard of it being problematic. Mary or anyone else, do you have anything to share regarding that?
So this is Mary Childs. I think that we have to look at it on an individual basis. If you have residents who independently go to those areas and assist themselves, and those residents may have some severe cognitive impairment, they may not be consistent with infection control, then you need to make sure that you have systems in place to minimize the transmission of any infection. As I look at many of the newer facilities and those that are being renovated, we see that most of them are removing water fountains from the hallways and are working on other ways in which to provide appropriate and frequent hydration.
Thank you. So we have another question. I think, Mary, you might want to answer this one. How will we know if a regular POC or a DPOC, which is directed plan of correction, is required when we receive our 2567?
Thank you. When you receive the 2567, you should also receive a cover letter from your state survey agency. You need to read that initial cover letter very carefully. If there has been a deficiency at a D level or higher, D is in David, you will be required to develop a plan of correction unless that deficiency was classified as past non-compliance. The DPOC is a separate and entirely different action, and it will also be identified in that cover letter. In addition to the cover letter, when a DPOC has been required, while the cover letter mentions the fact that you have to do it, most facilities are receiving a separate attachment that gives particular instructions about what has to be included in the DPOC. And that set of instructions is where you will often find the requirement to complete the root cause analysis or to do some directed in-service training. So the short answer is read the cover letter that comes with your 2567.
Thank you, Mary. And now, Allison, a question for you. Do you have suggestions for a tool to measure hand hygiene compliance?
Yes. So, well, I'm kind of, if you could, and I'm sorry, I think it was Alyssa that asked that question. If you wouldn't mind reaching out to me, we actually do have a hand hygiene compliance audit and tracking tool that's been developed. And so if you wouldn't mind reaching out to me via email, I can facilitate getting those tools to you.
Thank you, Allison. We have a question or a comment from Pam Dozier, and I'm not sure, Pam, if you were able to raise your hand. What she said was she was unable to put this in the chat. Okay, we did an RCA for dementia residents who are out in the hallway and will not keep their masks on. We came up with the solution of purchasing clothes racks that can fold into an L shape, and we put a clear shower curtain on them. These are placed around the residents to create a barrier from other residents that might roll up to them. So, Pam, I'm not sure if you would be able to raise your hand and explain that maybe a little better. I'm not sure if that's working, Amy.
Yeah, let me, Pam, I have just allowed you to talk. You should get a prompt on your computer screen to unmute yourself. There you are. Hi, Pam.
Hello. Hello. I was just putting that in response to Allison's question about anything that somebody had done a RCA with and come up with a solution. And we were having a difficult time with keeping social distancing, physical distancing with our residents that have dementia that are sitting in our day area. And so we did some brainstorming and we figured, we came up with this solution of taking this clothes rack and these clear shower curtains that we can put around them. It protects them from anybody that might come up right up to them. And we have a mask with them or a mask on them if they'll leave it on. But it's provides an additional barrier for physical distancing to maintain that for our dementia residents that, you know, just roll up to other people that may be sitting there in the day room.
Thank you, Pam. We have one more question next. Again, hand hygiene. Are there ideas for hand hygiene stations, especially for our precautions area for new admissions? And two, she worries about cognitively challenged residents. Any other thoughts on hygiene stations?
This is Allison. I'll have to do some investigating on that, Sharon. And I'll do that and share. We'll share what we're able to find. Mary, have you heard of any ideas, or even Joanne?
So this is Mary. I'd like to do some investigating also. I do know that on the CDC website that there are some guidelines and some suggestions for caring for residents who are on a memory unit. And I think sometimes we tend to shy from looking at those simply because we don't technically have a unit. but many of those guidelines are applicable wherever a resident resides that may be cognitively impaired.
Okay. Thank you, Mary and Allison. So we'll just do these last two questions are kind of similar. Will HQuinn members get the tools referenced? And the answer is yes. Those on the call that are HQuinn members after the call should get this automatically. And if you're not an HQuinn member, if you could reach out to your state representative, we can work with you to become an HQuinn member. And there was a question that I think disappeared that had to do with the audit, audit and tracking tools. And again, I think that would be the same if you can reach out to your state representative. And also in 2 weeks, our next session is on auditing and our tracking tools that will all be shared at that point.
Mm-hmm.
And that's all the questions I have right now.
Okay, and we are at 2:31. So to be respectful of everybody's time, if there are no other questions and no one has their hands raised, we're going to end our session. And I would like to thank you all for joining us today. And most of all, thank you for all you're doing to serve your residents and your staff. You are our heroes. And I hope everyone has a wonderful rest of the day and week. Thank you so much. Bye.
Bye-bye.